So, good evening, everyone. I am Dr. Abhinav Jain. I am a gastroenterologist at SIMS Hospital, and today we are going to discuss endoscopy in the era of COVID-19. How this is going to affect the practice and what precautions we have to take in view of the COVID-19 in India. So, why are we talking about endoscopy? First, we'll go through the problem that endoscopies faced in this time where coronavirus is spreading fast. We'll go through the indications of endoscopy, what constitutes an emergency, what constitutes a routine endoscopy and can be delayed, how to use a PPE, and this is the most important part of the presentation, how and which PPE to be used, the personnel in the endoscopy suite, and finally the disinfection of the endoscopes. As of today afternoon, there are about 17,869 cases of COVID-19 in India, out of which about 14,400 are the active cases. The problem with endoscopy is this: it is peri-endoscopic transmission. It has been reported that peri-endoscopic transmission has occurred in China and Italy, and people who are performing endoscopy have got the virus. From India, there are a few gastroenterologists, one from Delhi, one from Jammu, one from Mumbai, and there are a few friends, gastroenterologists in the US, who have reported that it has spread to them. COVID-19, the virus is present in all the secretions except for sweat. This includes the respiratory secretions, saliva, and stools. When we perform the endoscopy, we do continuous suction, we push in saline, and we generate a lot of aerosols. And this can lead to infection. When we perform such aerosol generating procedures, the risk is about 4 to 5 times as compared to other occupations in which the aerosol generating procedures are not there. So, endoscopy is at particular risk for this transmission. The risk is higher, in fact, as compared to endotracheal intubation or bronchoscopy, because endotracheal intubation would take about a few seconds, bronchoscopy would take about 5 to 10 minutes, but a procedure like colonoscopy can easily take 20 to 30 minutes also, and some difficult procedures or difficult interventions can take as much as 45 minutes, and ERCP can go on for as much as 1 to 1.5 hours also. So gastroenterologists are at actually more risk as compared to pulmonologists for performing bronchoscopy. So what are the indications of endoscopy? Majority of all the guidelines, the American, the Indian, and the Asia Pacific, they have divided the indication of endoscopy into three. One is the emergency or the urgent endoscopy, which has to be done, like acute gastrointestinal bleeding, upper bleed or lower bleed, perforation, cholangitis, foreign body, perforations, when we require GI access for urgent feeding, like in patients with absolute dysphagia, or those obstructions that require stenting. Semi-urgent endoscopies are those which has to be discussed on a case-to-case basis. In these patients, the overall benefit of endoscopy would be that their natural history might change, and these are the patients which we cannot postpone for more than a few days. This would be patients who require endoscopy treatment for neoplasia like EMR, ESG, endoscopy for highly suspicious case of cancer, small bowel enteroscopy for occult GI bleeding, or ERCP to relieve the obstruction in hepatobiliary cancers. Elective endoscopy, this can be deferred. Patient will not suffer if we defer these patients for more than a month. This includes our routine diagnostic endoscopy like for dyspepsia, GERD, without any alarm symptoms. If there are alarm symptoms, it needs to be done. If there are no alarm symptoms, we can wait for more than 1 month. All surveillance endoscopies, including those in patients with cirrhosis or varicose surveillance, therapeutic endoscopy for non-cancer disease, other ERCP cases like asymptomatic stones, therapy for chronic pancreatitis, US for benign diseases, and endoscopic therapy for benign diseases like bariatric or GRD. This can wait for about 1 month. The Indian Society of Gastroenterologists, they recommend that you risk stratify the patients based on three things: the symptoms, the respiratory symptoms, fever, cough, dyspnea on exertion, contact with the suspected or confirmed case, and travel history. Those who do not have either of them, they are considered as low risk. Those who have symptoms but no history of contact or travel, or those do not have symptoms but have a history of contact or travel, those are intermediate risk. Those patients which have symptoms and either a history of contact with a suspected or confirmed case or a travel history are considered high risk. But the guidelines keep on changing, and I would recommend that for everyone, when we have a patient, we should consider them as high risk for COVID-19 because patients can be asymptomatic with the virus, and it will lead to a lot of confusion. So all the patients should be considered as high risk, and we should. I'm against risk stratification right now with the present scenario. Now we come to the personal protection that we endoscopists have to use. It includes mask, head cap, a gown, goggles or eye shield, gloves, and foot cover. So this is me in the endoscopy room last week when I was wearing the full gear. It's very hard to even recognize me in this picture. So the head is fully covered. In fact, we are wearing this complete gown which covers from the head to the toes. This is one single gown. The almost the entire to the side of face, everything is covered. I wear either goggles or face shield. I would recommend a face shield because it covers the face area more completely. Mask N95, which is either FFP2 or FFP3. Now, N95 is not synonymous with FFP2 or FFP3. FFP2 basically filters up to 93 to 94% of all particulate matter. N95, like the name suggests, filters 95% of all particulate matter. FFP3 masks, they filter about 98%. Then there are N99 masks and then N100 masks. These are not easily available right now. N95 is considered equivalent to FFP2. N95 is also considered equivalent to KN95, but there is some subtle difference between this. Now there is some confusion amongst various guidelines about which mask is to be used, whether it has to be an N95 mask or a normal surgical mask. Now, AGA, the American Gastroenterology Society, recommends N95 over surgical mask. The European guidelines, the Asia Pacific guidelines allow surgical mask for low risk patients, patients who do not have symptoms or do not have a travel or contact history. The Indian guidelines do not have any such specific recommendation about which mask is to be used. My personal recommendation is to use N95 mask for all the patients because we never know when the patient might be carrying the disease because there is a possibility of asymptomatic transmission. And as endoscopists, we are doing an aerosol generating procedure, and it is very important for us to be protected and use N95 and do not use a surgical mask. Gloves. It is preferable to use double gloves. When we use double gloves, the first glove has to go inside the gown, and the second glove has to go above the gown so that it becomes airtight. There is only one single study which has shown the benefit of double gloves over single gloves, and on the basis of this, we can recommend to use double gloves. This is a waterproof gown. We'll discuss about what this Army 3 means, but this is a special laminated gown that the hospital has procured from the US. This covers the feet, the entire body, as well as part of the face. And finally, the shoe cover if your gown is not covering the shoes. Because a lot of secretions fall on the ground whenever doing the procedures, and so we have to be careful and cover the shoes as well. Now, as far as the gown is concerned, we have an army level. Army 1, 2, 3, 4. Army stands for the Association of Advancement of Medical Instrumentation. They have defined the level of protection on the basis of these numbers. 1 is minimal protection to 4 is the highest protection. These are part of the gown which are critical. A and B, the sleeves up to the elbow and the main trunk part. These are the ones that are the most critical zone in a gown. C is not so critical, and D is usually at the back and it may not require that much protection. So the Asia Pacific guidelines recommend that the low risk patient, for them Army level 1 is good enough. But for the high risk or the COVID confirmed patient, Army level 3 is recommended. Usually in practice, Army 2 and 3 should be sufficient for gastroenterologists performing endoscopy. Army level 4 is the highest protection. It is for those surgeons who have their hand inside the body cavity of the patient or who has to deal with a lot of contamination, like orthopedic surgeons or GI surgeons. For gastroenterologists, Army 3 is good enough. Again, I do not recommend following a risk stratification. I think we have to consider all the patients as high risk and all the patients as suspected COVID and use the Army level 3. What do we use at SIMS? SIMS has procured a DuPont Tyvek 400 gown, which I was wearing in this here. So this DuPont Tyvek 400 suits, they are Army level 3. Now this Army level does not apply to the plastic gowns which we use. We wear the plastic gown above this surgical gown so that it does not get contaminated that easily, and then this can be reused. Now the sequence of putting the PPE on and donning it off is also very important. First, we put on the gown, then the mask or the respirators, then the face shield or the goggles, and at the end we put on the gloves. If you are using double gloves, first we can put on one glove and then at the end the second part. When we remove the PPE, we have to be very careful. First, we remove the gloves. We use the gloves of one hand to pull the gloves of the other hand and remove them, and then slide the ungloved fingers to remove the gloves of the other side. This is because the surface of the gloves is contaminated and those cannot be touched. In case you accidentally touch them, you have to immediately wash your hands with soap and water or with sanitizers. Face shield, again, you cannot touch the front part of the face shield, you have to remove it from the back. Next, we have to remove the gown. Again, we have to take care that we do not touch the sleeves part because those can be contaminated. We have to remove from the back and then pull it away from the body without it touching any part. And at the end, we remove the mask. Again, remove it from the back without touching the anterior surface of the mask. And at the end, we wash our hands with soap or we use sanitizer. So again, gloves, then face shield, then gown, then mask, and then hand wash. So if you are using double gloves, we can remove the inner gloves last. Okay, so if you are using double gloves, and after we remove the mask, then we remove the second pair of gloves. So when can we discard? After one endoscopy procedure, we have to discard the gloves. Mask we can use for one single session. So if we, in a single session, we have planned 2 or 3 endoscopies, we can use the same mask for the entire session and then discard the mask later on. It is not recommended to reuse the N95 mask for such for endoscopies or aerosol generating procedures. Although N95 mask can be reused for routine OPDs or for routine indoor visits, but not for endoscopy because it has not been tested in that. When we reuse N95 mask, either after some procedures like if we disinfect it by vaporized hydrogen peroxide or by some other method, it loses its efficacy a little bit. And so for endoscopy, we should always have a fresh pair of masks. Only essential personnel should be there in the endoscopy room. There should be no trainees. We should not take out personal belongings like mobile in this. We should not pick up the calls between endoscopies. During intubation, only anesthesia team should be present. We should avoid switching of personnel during the endoscopy. So, reuse of PP again. The gown that we have procured that DuPont Dieback gown, which can be reused by ETO. Now, up to how many times we can reuse, it's not uh, confirmed, but we can reuse it to 2 to 3 times and then divide the cost to the patient. The face shield can be cleaned with sterilium followed by ETO. N95 should not be reused for procedures like endoscopy. We have to be practical. If they are in low supply, we might have to reuse. The best method is vaporized hydrogen peroxide. If not available, we can use UV, ETO, or even we can use liquid hydrogen peroxide. Methods like autoclaving or dry heat are not good. Those lead to damage of the surface of the mask and then leads to decrease in the efficacy. ETO again, it's not a good method to use for the N95 mask because there is some residue of ETO and then those will be inhaled when we reuse a mask and those have health consequences. The rest of the things can be discarded like gloves or the boot wear. Disinfection of endoscope. Presently, disinfection of the endoscope will continue as per the standard guidelines. We do not require to run a double cycle or to keep them longer. We do what we are doing currently and there is no change presently. So endoscopy suite also needs to be disinfected. For low risk patients, we can have the standard policy. For intermediate or high risk patients, those who have contact severe symptoms, we have to disinfect at the end of each procedure, taking care that we disinfect the furniture, the trolleys, all the surfaces that the patient might have come in contact with. Lastly, we might be called to do endoscopy in a COVID-19 positive case. Uh, every attempt should be made at conservative management in these patients. A recent case was published from New York where they managed 5 cases of hematemesis in a single hospital with conservative treatment and all the 5 of them improved. They did not do endoscopy in a single patient. It has to be done in a negative pressure room. A negative pressure room is where the aerosols which are generated do not escape out and they are sucked in. Instead of using N95 mask, we might use powered air purifying respirators. Those are PAPR, and this is what a PAPR looks like. It's a full face mask which takes the ambient air and remotely filters it over here and then it recirculates it. It is more secure than an N95 and it is more comfortable to wear for a long duration. We have to disinfect everything, the scopes, the endoscopy room at the end of the procedure. If usually the endoscopy rooms are not negative pressure rooms, so we might have to take the patient to a special room where we have to do the endoscopy. And those rooms have to be disinfected or fumigated at the end of the procedure. And these patients also require a separate post-recovery area. Thank you. If you are interested to read more about this and you want the original European, American, Indian, or the Asia Pacific guidelines or other papers on this, you can email me and I will email you those papers. Okay. Thank you everyone for coming.